Good morning. My name is Rodney Amron. I'm an emergency physician. Today we're going to be discussing the evidence-based diagnosis of dizziness. So why pursue an evidence-based approach to dizziness? Number one is that stroke is one of the big three causes of misdiagnosis. And then, furthermore, in the subcategory of stroke patients, the dizzy chief complaint is the highest rate of not only misdiagnosis, but also over-ordering or inappropriately ordering tests. And this increases spending on a national level to about $10 billion mostly in the form of unnecessary MRIs, unnecessary CTs, and admissions. So the approach to the dizzy patient has changed over the years. Initially, when I was taught, the approach was to ask, so what do you mean by dizzy? And if it's lightheaded, then you go one route, and if it's spinning, you go another route, and you determine whether or not it's an acute onset, which points peripheral, or if it's an insidious onset, which points to central. That method has been proven to be unreliable. Instead, there's a method called triage and titrate. Triage refers to, is this dizziness plus some symptom? Titrate is a mnemonic to remember timing, so you narrow the differential diagnosis by classifying the dizziness attack pattern as episodic, acute, or chronic. Triggers. After you determine if it's episodic, acute, or chronic, then you seek the underlying pathophysiologic mechanism by searching for obvious triggers like positional or exposures in the review of systems. Then you pursue a targeted exam and the targeted exam that we usually do differentiate between dangerous causes with a timing trigger category using bedside findings and emphasizing targeted eye movements. And then lastly, we do tests, which is the best laboratory tests are MRI versus ordering blood work in order to rule out a dangerous cause. So timing can be separated into episodic vestibular syndrome, or acute vestibular syndrome. Episodic vestibular syndrome is defined as something that is less than 15 hours, and acute vestibular syndrome is anything greater than 15 hours. But the way I like to think about it is that this is present only with a trigger, so not present currently. And this one has symptoms. So for example, someone says, oh, I got out of bed and now I feel dizzy, but if I sit absolutely still, I am not having any symptoms. That's episodic vestibular syndrome. Or I only get worse when I sit up. That's episodic vestibular syndrome. Acute vestibular syndrome is I just got hit by a boulder and now I have persistent symptoms. Or I went into my house and it was a cold day and we turned on the heater and now I've got a headache and I'm dizzy, which is carbon monoxide poisoning. Or I had an inner ear infection a couple weeks ago and now I woke up and the room is spinning and I'm spinning right now and I can't find it. These acute vestibular syndrome patients look quite ill. The majority of patients we're going to see with dizziness are episodic vestibular syndrome patients. To the order of like 80%. And the minority will be acute vestibular syndrome. And of those two categories, there's a super small risk of having stroke, like less than 5% of each of these. As a consequence, this is categorized as a high risk, low frequency disease process, because we see a lot of dizzy patients, but not all of them have high risk features, and we don't want to over test all these patients. So that's why using a systematic approach like this every time will save you missing a stroke, but at the same time allow you to efficiently manage your patients. So with episodic vestibular syndrome, we divide them into triggered or spontaneous. In acute vestibular syndrome, we group them into triggered, like a post-exposure, or spontaneous. With episodic vestibular syndrome, if it's triggered, then we perform a test. Either we do a Dix-Hallpike, or we do a supine roll. The Dix-Hallpike is for posterior canal, BPPV, and supine roll is for horizontal canal, BPPV. In the spontaneous patients, this could either be Meniere's, vasovagal, or a atypical presentation of a stroke. In acute vestibular syndrome, if it's been going on for greater than 15 hours or they currently have symptoms, it could be post-exposure or spontaneous. If it's spontaneous, then we will pursue one direction, and if it's post-exposure, we will pursue another. Post-exposure can be head trauma. It can be toxins, like I said, carbon monoxide, or illicits like alcohol can even cause you to have this kind of behavior. Some anti-seizure medications, like Dilantin overdose can do this, and gentamicin can do this as well. But for spontaneous AVS, you need to perform something called HINTS plus. So an important differentiating thing to remember is that if the patient has episodic syndrome, you do not do a HINTS exam. You only do a HINTS exam. You only do a HINTS exam for acute vestibular syndrome. In acute vestibular syndrome, patient has persistent symptoms, and the first thing you want to look at is nystagmus. So if they have anything other than the classic one direction beating nystagmus, either left beating or right beating, then you classify it as central. You're done. You don't have to go any further. You call the neurologist and get the MRI. So if it's downward beating, if it's upward beating, if it is beating to the left when you look to the left, if it's beating to the right when you look to the left, then it needs to be evaluated with an MRI. If you do not have one direction beating nystagmus, you cannot use HINTS, and you have to pursue a central etiology. Next is test of skew. Now people have baseline skew deviation to the left and right. This is a strabismus, or an esotropia, exotropia. Anything like that, a strabismus is classified as peripheral. If you have an upbeating or a downbeating, then that's called central. And that's called skew deviation, which is test of skew. Now, one last thing is hearing. So a common mimic with a anterior inferior cerebellar artery stroke is someone who has a HINTS exam that looks peripheral, but they are deaf. So if they have decreased hearing, it's central. And the head impulse test is a test that tests for a vestibulo-ocular reflex. If there is a positive saccade,
it is peripheral. If there is a negative saccade, it is central.
In benign positional vertigo, you might say, hey, but they have an upward beating nystagmus when you do a Dix-Hallpike. And when you do a supine roll, they'll have lateral nystagmus. The reason why that is not a central process is because that's in episodic vestibular syndrome. So patients may have some baseline lateral nystagmus with horizontal canal at rest, but for the most part, the symptoms are only triggered on movement. And then for benign positional vertigo, you can only trigger that with Dix-Hallpike. This is patients who are sitting there and they have downbeating or upbeating nystagmus at rest. If that's going on, you have to consider a central process. Lastly, when we were talking about the triage techniques, the Dizziness Plus, we looked at dizziness plus chest pain, shortness of breath, headaches. Any of this would point you away from the diagnosis of benign positional vertigo and would point you in a different direction. One I'd like to consider is orthostatic hypotension. Orthostatic hypotension is a hypovolemia and can cause dizziness. But if you don't have a drop in blood pressure, this can definitely be a stroke because sometimes bilateral carotid stenosis can mimic orthostatic hypotension. Hopefully this was helpful.